Awesome. Thanks, Nate. And good afternoon or good morning to each of you. Certainly a pleasure to be back with the NAEMSE community. And thanks for hosting today's program. As Nate mentioned, last week, we talked a little bit about those core practices for infection prevention and specifically some of the risks related to EMS and can we prepare our providers of the future, keep our faculty safe, and also keep our current providers safe. This week, we're going to build on part 2 of that and talk about some of the ways that we can accomplish our goals, right, during an ongoing pandemic. We'll talk about some of the new tools and resources available through CDC's Project Frontline, and then also what we can do to serve as ambassadors within the community to stop the transmission of COVID-19. As Nate mentioned, if you do have any questions as we go through, feel free to go ahead and interrupt me and type those in the chat box, and I'll do my very best to answer those as we go, as well as at the end. So we'll jump right in and just start with a little bit of a pictorial story here, right? Where we have providers that are in a very difficult circumstance for a long period of time. So our resiliency is down. Some people may be exposed to personal protective equipment for much longer than before. And now you're dealing with this in the classroom as well, which can create all kinds of potential issues. And so that sort of brings us to today's topic, which is how do we ensure that we're teaching the right information, but getting a good learning, that episodic learning where people are going to walk away with the core skill sets to stay safe, whether they're a current student, a future student, or an actual practicing provider. And so as we think about this, there's a couple challenges that mainly come to mind, right? There's that generalized confusion about how the virus truly transmits and what's the most likely source. Is this something that we should be very concerned about within a classroom? Should we be focused, for example, on the HVAC system versus the equipment? What about the types of PPE that are available? You know, now we've got a national glove shortage, which is very problematic for many of us. Certainly, we've changed the way that we're configuring our classrooms, right? Where we're having a sort of a different risk profile. If we've got 5 or 6 people in an area, how do we really train on basic EMS teamwork if we can't keep people in an area together? And certainly, we're seeing a lot of people move around in the field. We see so many practicing providers go to the EDs. We see a lot of faculty members that are leaving for other roles. We see practicing providers that are just burnt out. And so that overall turnover rate can be very problematic for us, both from an educational standpoint, as well as from a continuing education perspective. And then what about point of care testing? You know, wouldn't it be great if you had students that were trained on actually assessing for risk of COVID, could do a diagnostic rapid screen, and then know right off the bat, does this patient in front of me have COVID, right? Similar to an ISTAT type modality where you can get that point of care determination. And then how are we changing our educational methodologies? What are we going to do to still maintain our curriculum and still give that student that great enrichment experience, but also keep everybody safe? And we'll talk about some of the ways that we can do that today. So I thought it make sense to sort of take a step back and think about how does an infection actually occur in the first place, right? And there's a couple different pathways that have to link up together in order for us to cause not only the infection, but the unfortunate realities of replication and damage to the body. So the first is we've got to leave that original host, right? How does that particular organism get from point A to point B? I always think about this like, a duck crossing a highway. It's got to go from one side, whether that's the southbound or northbound side, to the other side, and it's got to successfully make it, right? It may not survive the transit. The product, if you will, the virus or the bacteria may not be delivered. There's also got to be a susceptible host, right? And then we've also got to escape our normal natural immune responses that we have within the human body. Only then can we actually have not only the infection itself to take place, but we also will see that tissue damage. So if we think about sort of signs and symptoms, right, back in March or February of 2020, it was shortness of breath and fever, right, the classic symptoms of COVID. And then we continue to add to that. There could be GI symptoms. Certainly, you may have students and faculty and providers that are participating in the collection of clinical specimens. You've also got a changing incubation period. We're starting to see that sort of shrink down from that traditional 14 days down to 10 days with certain circumstances. And then now we've got to add on to that another layer of complexity about what if you as a faculty member or your students get vaccinated? Do I still need to quarantine, for example? The second one is to sort of think about organization-specific defenses and sort of problems, right? You may have viruses that are enveloped. You could have bacteria like C. difficile that are spore formers. You could have, different environmental risk, right? This is a big one for those of us that live in the South, for example, where you've got lots of humidity and temperature that changes over time. There was this thought with COVID, for example, that as it got colder, those viral particles would be able to travel for longer distances of time. That's not been fully proven out. And then certainly things like the types of surfaces and equipment and devices that we have. Is there really a big risk if we have students that are sharing blood pressure cuffs or sharing stethoscopes and some of the like? A year ago, we probably would have said a lot more than what we would say today. Now, how does this thing even get delivered, right? And this may be applying not only to COVID, but other things. Is it truly an airborne route? Is it an environmental surface? Is this something that I need to inhale a large amount of viral particles, for example? What if I have like a bloodborne pathogen and I get a splash into my mucosal membranes? There are certain organisms, unfortunately, that are transmitted pretty easily with water. Legionella is one that comes to mind, with cooling towers. And certainly our 10 deadly weapons of our hands, right? Where we're going to have that potential opportunity for transmission from us to the patient and back and forth. So if you think about this, now we've got an opportunity because we understand the virus, we understand the transmission, we now have good surveillance testing, but what do we have to think about relates to sort of ending the pandemic? And a lot of that's going to be around immunization and vaccination. There's also that potential in the future for more of that post-exposure prophylaxis, similar to what we would do for high-risk exposures for HIV or hepatitis. So let's just sort of play this out in a current context. So let's say you've got a student that is out in a clinical setting, they get poked with a needle, that needle is grossly contaminated, you find out the source patient is HIV positive, they are not undetectable, right? So you sort of have this good scenario of where you understand all this information and the patient complies with the request. And now you've got a student that's at high risk for development potentially of HIV. Or hepatitis or whatever it may be. That post-exposure prophylaxis or immunization is going to be very helpful. The same is true with COVID, right? How do we sort of think about, as it relates to students from a vaccination standpoint, faculty members that might be at high risk, as well as our practicing EMS providers that we're supporting through continuing education, right? And at the end of the day, what we're trying to do is not just avoid the contamination, but really more importantly, try to avoid the actual development of infection and then the replication. Particularly with viruses and bacteria, they replicate extremely fast. And so we've got an opportunity to stop that up front, but it really requires a lot of positive momentum on the forefront to do that. So let's go back to sort of the overall chain of infection. And the reason I like this is that when you think about educating EMS providers that are new to this, right, you can use this as a poster. And frankly, you can talk about any issue related to basic infection control off this one particular image, right? So for example, if I say, let's talk about flu, right? Flu is going to be transmitted via what? It's going to be normally an inhalation, right? It's going to be some type of contact with droplets. We don't need an N95 respirator as an example. We know that flu can live on surfaces. So we want to disinfect the environment. We want to wash our hands, and we want to make sure we're using good personal protective equipment. The other piece we could talk about is, well, how does flu get into another person? So what happens if I come to work and I'm that sick student or that sick faculty member, that sick provider, and then I come to work sick and I'm no longer wearing PPE, right? And it's because maybe I need that paycheck as an example. So also teaching students the effective domains of ethics and some of the other things about, don't show up to work sick. Let your instructor know if you're ill. And, for our faculty members, ensuring that there's a process in place to cover classes as needed. And this has been a big issue with COVID, right? Because of the duration of the quarantine period that was required. The other piece is to think about sort of the susceptible host model. 10 years ago, this would have been, this is comorbidity patients, this is folks that are really ill. And now it really could be the majority of us. Folks that are tired and fatigued and stressed and worn out can all be susceptible hosts that we have to think about. So I like to keep things extremely simple. And I found that students appreciate the same approach. So again, if we use sort of the graphic I just showed you and overlay with that this one, you can really have long-term conversations about the majority of the pathogens that a student or faculty member will ever face. So if we think about MRSA, how is it transmitted? Well, it's contaminated hands, it's certainly in the environment, and it absolutely can live on patient's skin. We'll use another one, C. difficile, right? Spore-forming organism, contaminated hands absolutely but it requires the removal with soap and water, not an alcohol-based hand rub. Right? That's problematic because in an ambulance, we don't have soap and water. Contaminated environment, absolutely. The spore can live up to 8 months in the environment, but we don't really have to worry about that on the human skin. Let's use another one. Let's use COVID, right? Certainly can live on the hands. It can live on environmental surfaces, but we really don't have to worry about it on the skin. And then if we take another one like VRE, all three of these can play a role in that. And so the point in sharing this is that regardless of the pathogen you discuss with your students, you can really classify them into one or more of these basic buckets. What's great about this is that right underneath this, you can sort of add a little bit of how do we stop that potential transmission. So with hands, if it's contaminated, we can wash our hands with soap and water, or we can use an alcohol-based hand sanitizer. If it's an environmental surface, we can use a cleaner or a disinfectant, whatever is most appropriate. And then with skin, we need to use some type of good, durable skin antiseptic. Right? A lot of times in EMS, we're using an alcohol prep pad or something of that nature. But in reality, the CDC guidelines really suggest the use of chlorhexidine gluconate with alcohol, which gives you a better immediate kill and a good persistent kill. But again, this is a quick, easy way to break common sort of complex issues down related to infection transmission. So from that, you can then create like a Jeopardy game, right? That's sort of that name that route. So how are these different organisms transmitted? And what I would add to that is, have this maybe pop up on the screen, or you can do a Jeopardy template, and there's many available online, and then give the students the tools necessary to appropriately protect themselves as well as their coworkers. So for example, if I've got somebody that is going to have Mrsa as a potential organism, then I know that I need contact precautions. I know that I'm going to need to wear a gown and gloves. I'm going to need to wash my hands and disinfect that environment. So have the students go ahead and suit up and actually wear the PPE correctly. The same can be true with things like influenza, to make sure that they wear a surgical or procedural mask. If we're dealing with COVID, right, we're going to go a higher level, and we're going to go with some type of respiratory protection in the form of an N95 or higher. And with Ebola, of course, we know that's a very different animal just due to the amount of body fluids that might be present there. Again, this is a quick, easy way to get your professional students as well as your educators to think about the route of transmission. So one thing to really consider is, how are these particular organisms truly transmitted, right? And especially as it relates to classrooms and your non-clinical areas where we're doing teaching. If we were to use COVID as the example, there was, several months ago, CDC put out what I considered a very controversial statement about COVID could be airborne transmitted. And I don't know about you, but I really kind of revolted to that and thought, why in the world would you use that term? Because when we think of airborne transmission, we're thinking about small droplets or small particle size, should I say, that sort of transfers for long durations of time and can stay suspended in the atmosphere for a long period of time, right? TB, measles, stuff like that. That is not what we see with COVID. What we do, however, see is potentially prolonged aerosols, right? Where we have stagnant air environments, a lot of viral particle in the air, and the air simply not moving. Well, that sort of lines directly up with an ambulance. And so we need to think about ways to improve the air quality in the back of trucks, particularly teaching students and providers about turning on the exhaust system, making sure you're running the air on high. If you're in the front compartment, to make sure you're running the air from the outside. Right, you can sort of create your own negative pressure by even putting windows down as an example, to try to do that. But again, we need to make sure folks are aware of what types of organisms are going to be droplet versus airborne. And the droplet particle size, that's super easy to catch with surgical mask. But we always need to be wearing that eye protection, because just as something can get in our nose and our mouth, it can also get into our eyes. And then things like vector, if we have a needle stick, like I mentioned early, teaching the students about what pathogen is going to be most impactful here. And frankly, it doesn't matter what the bug is. It's more about what's the route of transmission. I'd almost rather have providers and students know, this is airborne, so I need to wear an N95. This is droplet, so I need to wear a surgical mask. This is contact, so I simply need to wear a gown and gloves. Right? That's going to really keep them more safe than memorizing 50 or 60 different organisms that, yes, they'll see them, but it's really not going to directly impact the clinical care that they give in the pre-hospital environment. And part of this is about standard precautions, right? Keeping people safe all the time based on the assumption that I might have something and you might have something, and therefore I'm going to keep both of us safe through good, practices like washing our hands, appropriate use of gloves. I'll tell you that there's a great Medscape video out there if you are ever interested. It doesn't offer CE credits anymore, but it's a 6-part video series that I was fortunate enough to be a part of with CDC, and one of them was about the use of gloves. And it was astounding to see the literature and the research that CDC had about how people in healthcare just completely incorrectly use gloves, right? They put them on incorrectly, they remove them incorrectly, they don't wash their hands when they remove them. I could go on and on for days. And so our risk assessment should really be based on the specific type of role, right? The risk of exposure and also the duration of exposure. So if I've got somebody, for example, that is a COVID positive patient, and let's say they're going on an interfacility transfer that's 8 hours, is it less likely, for that provider in the back of the truck to be contaminated, or more likely? Well, I would say absolutely more likely, because the duration of exposure is going to be much higher. Their resiliency with the personal protective equipment is going to drop just based on the length of that transport. So this is where we may say, based on the risk assessment, we need to arm that provider with a PAPR or something like that. That's going to be a little bit safer for that long duration of transport. So as we apply contact precautions, one of the ways that I like to teach this personally is to actually use a squirt bottle approach, where I get a gown, you get a student, you give them sort of an impermeable membrane that they can put underneath. Maybe it's a chuck pad is what I tend to use, and then actually have a squirt bottle that's got water with red food coloring, right? And of course, we're doing this because we want a visual depiction of, hey, let me show you what contamination on your PPE looks like. Because right now, you don't normally see contamination unless it's stuff like fecal matter or something like that, or some other body fluid that you can physically see. Have the student stand in front of you and give them the 4 different types of gowns. There's level 1 through level 4. Spray them with that red food coloring on each one and see how quickly it penetrates through certain levels of gowns, like level 1 and level 2, right? This is a quick, easy way for students to say, wow, I didn't realize that all that stuff could be sticking to my gown, and then it could also go through to my uniform. And so having the right level of protection is going to be helpful. FDA has anticipated that about 50% of the gowns that are sold outside of the traditional medical channels are not even FDA rated for protection in healthcare. So that could be a big, big problem for us as we think about risk factors. So I wanted to give you a quick case study that hopefully will give us an opportunity to sort of think about where a potential risk may be for faculty as well. So this is just a scenario that I came up with that unfortunately has happened to several of my colleagues. And it's an EMS student that is currently undergoing chemo treatment. And they had a COVID exposure and they turned positive, right? And the health department does contact tracing and they trace that back to the EMS clinical skills lab. Right. There's also 5 other students in that course that are ill. And now this particular student, the one that's receiving chemotherapy based on their comorbidities and being immunocompromised, is now hospitalized with a very poor prognosis. So a couple of questions come to mind to think about from sort of a protection standpoint. Number one is sort of, what's your overall policy and procedure, and what documentation do you have to show that you are compliant with the current CDC guidance? And this is a big one because the guidance seems to change every single week about something. Right now, luckily with PPE and hand hygiene and disinfection, that guidance has really not changed significantly. But it's really good to keep a copy of that policy along with any substantial supporting documentation from CDC or other organizations stapled to it, right? So you can show, hey, on March 2nd, this was our current policy based on this information from CDC, which was current as of the last 30 days, right? It's a very good defensible position to be in. Number 2 is they're going to want to know, what precautions did you take, right? Did you have students wear PPE? If so, what kind? Was it PPE that was reused? Did you reprocess it? Was it PPE that was appropriately cleared for the medical space, or was it something that was imported from China, which we've seen a lot of? Number 3 is one of the big ones, which is, what does that overall screening process look like? And unfortunately, places that I go, including hospitals, they're primarily relying upon temperature screening and asking the following question: do you have any new symptoms? Right? That tells me nothing. right? I need to have a poster behind me of the actual symptoms. The poster chart from CDC is a great one to use. And I need to ask them, do you have any of the following symptoms? Have you been exposed to someone with COVID in the last 14 days? Are you currently living with someone that is quarantined for COVID? Have you been outside of the country in the last 14 days or outside of your local geography? These are all things that we have to think about, especially to identify asymptomatic carriers that might come in and infect your class. A lot of people are using automated screening where it's done online or through an app. That's great to use as well, but just don't sort of, just rely upon temperature. And then number 4 is, what capabilities, if any, might you have through your student health department to actually do contact tracing? Are you going to totally rely upon the health department, which is overwhelmed and understaffed, right? And they also don't understand your environment. So it'd be good to have that proactive conversation up front. So when we think about droplet precautions, right, this is the majority of the infectious organisms that we'll be dealing with in an EMS environment. But again, the droplet precautions are only as good as they're applied. And so quick early recognition of, hey, this looks like a condition that would require me to put on a mask. One of the ones that comes to mind is measles, right? People may not have seen measles in their career before, but if you've got somebody with a fever and a rash, I'm putting a mask on, and I'm putting a mask on me and a mask on that patient. We also need to make sure that they appropriately fit. And so the principle of fit testing is a major issue of concern right now with OSHA. Right. And remember that OSHA exists for one purpose, to protect the worker. So it's all about making sure that we're fit testing, and we can't rely upon one specific mask to be the one that the student may wear or the faculty member may wear, because we know that PPE shortages continue to exist. So airborne precautions, right, can look scary like this picture. And when we think of airborne, we're thinking primarily of things that are going to have very small particle size, long duration of sort of travel, and they also have the ability to be suspended in the air for a prolonged period of time, right? And so measles is one of the ones that I use all the time as an example. If we were to take a room, and let's just say we put 50 people that are not vaccinated, never been exposed to measles, with one person in a closed space, about 90% of those people would contract measles. That's how infective it is, right? Now, we're certainly not seeing that same level of infectivity with COVID, thankfully, but certainly with variants like the UK strain, it's 50% more transmissible than the normal strains, right? And so what we're worried about here is to protect the respiratory system with tight-fitting masks that are going to have that proper seal. This is where things like having facial hair can be problematic, or if your facial sort of shape changes due to either gaining or losing weight. And so this is why we always want to continuously fit test people as things might change. Another great teaching activity that I personally like is the Glow Germ, right? Where you can use this, and it's basically a UV light that you spray a powder or a liquid onto hands. I've used this on devices and surfaces just to sort of show the route of transmission and how easily something can actually go from point A to point B. I like to start with this on the hands and not tell anybody. So you can sort of, douse the powder on a couple surfaces, maybe put it on the equipment. If you've got like a computer where students sign in, that's another great place to put it. And then, have the students put on PPE and have some of that where you can actually put it on their gown. And now they're going to go to certain areas, and you can see how quickly they contaminate the environment. This is a really quick wake-up call that's visual, right? It's in front of us, and then we can cut the lights off and shine the light. We can show every single spot that this was contaminated, right? This is a $25 experiment that really produces good results to say, if it's not even for your patients, which it should be, think about what you might be taking home to your family members, and getting in your car is another thing to think about. And that really drives us back to this concept of the hierarchy of controls, right? At the very top of this, you're going to see the things that are deemed most effective at reducing risk. But at the very bottom, which ironically is where PPE sits, these are the things that are least effective. So we spent a lot of time, money, and resources. We've made, millions and millions of pieces of PPE. And in reality, that's really the least effective thing that we can do. We can try to remove people from the hazard by not sending in our entire EMS crew, for example, to assess a patient. We can think about, as faculty members, breaking up learning activities, or, as weather permits, doing things outside, which is a great solution, but not really losing sight of we still need that team camaraderie as we build the future EMS educators and providers of the future. because eventually what we want to get to is sort of that concept of substitution or elimination. Part of this is going to be a widespread vaccination challenge, right? For more and more EMS providers and members of the public and other healthcare providers to get vaccinated. The overall vaccination numbers are certainly going up, which is great, but we've got a lot of vaccine hesitancy out there. And so it worries me greatly when we think about sort of the risk associated with that. And as it relates to PPE, the current data from CDC supports that many healthcare providers that actually contract COVID at work, where they can actually prove that, it is usually related to either one of two things. One is they don't have the right PPE in the first place, or they don't wear it. Or number two is they're not appropriately donning and doffing that PPE, right? So just as we put that equipment on, it's just as important to take it off correctly. And you'll notice here that on the left is the preferred PPE, meaning an N95 or higher for COVID. And then on the right is sort of when we're in a crisis mode where we don't have an N95 or higher respirator, we can then use a surgical mask. What we're finding a lot of providers are doing right now is they're always wearing a surgical mask, and that's also what's recommended by CDC, even within quarters. We certainly want to think about that as well for our students that are coming in. And in some cases, it may be advisable to have somebody wear a respirator. It really just depends on what type of procedures we're doing, especially for aerosol generating procedures. When students are in clinicals, it's a no-brainer. They need to wear a respirator for that. So here's a couple of videos that I think are fantastic, and they're super simple. This is something that every single student should be armed with before they ever leave your building and go into a clinical scenario, so that they're very well aware of how to put this on and how to remove it. I will tell you that wearing PPE it creates this different mindset of, well, I don't really need to worry about things anymore. And so all too often we sort of forget we have it on, and we're touching all kinds of stuff. And especially with our gloves, can become easily soiled. And so use these as a resource for your students as well as your faculty members. It'll also help them be compliant with their hospital policies and other sites where they may be doing clinicals. But the most likely risk as it relates to PPE is actually when you remove it. We saw this time and time again with Ebola, where people were popping off gloves, they were throwing things across the room by accident, right? And that can always contaminate people around you as well as the environment. So taking off PPE is really an important step in keeping safe. And then immediately doing hand hygiene so that you can actually sanitize your hands. So this is a poster that CDC provides that is very good. This is something that I always recommend having up in the classroom so that students can see it pictorially, and then require them to do it multiple times while we're looking at the poster, and then take the poster away, right? We're trying to build that competency with that skill. And that way they're very well accustomed to doing that once they get into the field. And we've also got, a different sort of approach to education that we're doing. And so, this was something that was published by NAEMSE and others back in July that really talked about how do we maintain sort of the integrity of our content and our programs, but also doing that in an appropriate way as it relates to COVID, right? Does it make sense, for example, to have someone come in wearing a respirator all the time? Probably not, but a surgical mask, yes. Does it make sense for us to have an increased focus in the clinical environment of care, like things like our surfaces? Well, certainly that's going to be helpful for all different organisms. But what we've not seen is a lot of transmission related to COVID in the environment. As a matter of fact, we've seen no transmission of COVID as it relates to the environment of care, the things that are non-living. Now, that certainly does not apply to places like the HVAC system and some of the other things where aerosols and other particles might live. But we've seen no transmission with blood pressure cuffs, pulse oximeters, stethoscopes, cardiac monitors. None of that exists. And so we just need to maintain our normal attention to detail with disinfection practices. There's also a different way that we can use to screen with, specifically our students that are coming in, faculty members and other visitors that might be participating, and students may be exposed to this as it relates to going into a clinical site, right? And I'm a huge fan of using the CDC tool because I think it walks us through sort of the right questions to ask in the right answer. There's another one that's called Ask Clara. If you've not seen it before, it's kind of cool, and it actually walks you through if you might potentially have COVID. So they sort of have the screening tool on the front end, and then if you think that you've had a high risk exposure and are worried about contracting COVID, they have one that's called Ask Clara that looks at it on the back end. but the modality of screening is really going to matter, right? If I'm just checking a temperature, or if I'm just saying, hey, do you have any new symptoms? Well, that's not very specific. Have you been around anyone who has COVID? Well, that's a very interesting question to ask anyone who's in EMS, because their answer is probably, yes, I've been around lots of people. And sometimes businesses, especially, don't know how to sort of engage with you after that. I know the first time I went to get a haircut, they asked me this outside of the front door when I was waiting for the young lady to do my hair, and she came out and she said, "I'm not sure we can let you in." And I said, "What's the problem?" And she said, "Well, you said you had contact with COVID patients yesterday." And I said, "Well, that's every day." And so sometimes we have to think about setting ourselves up for the right communication as well, especially if we're going to any specific sites where they may not have a lot of COVID. We need to be prepared to explain to them that, hey, we're taking the necessary steps to protect your patients and keep our students safe as well. As I mentioned earlier, there is guidance out there from OSHA that talks about COVID within the workplace, and they've got a whole page that's dedicated there that I've included the web link there at the bottom of the slide. What I like about this is it sort of walks through the various aspects of worker protection. And so Nate has posted that as well. But, there are sort of little nuances here, like what level of respiratory protection is required? How often should we do fit testing? Do we need to report this if there's any type of adverse event associated with someone who contracts COVID in the workplace and, for example, passes away? And so there are nuances related to federal reporting requirements that OSHA has published. But what I really like about OSHA is their concept of e-tools. If you've not had the ability to check these out, I would highly encourage you to do so. They have them on a wide variety of different healthcare topics. But the one that I wanted to call out today was the one for respiratory protection. So if you're sort of looking for, hey, I need to start from start to finish to develop a respiratory protection program that is robust and sustainable and is going to meet the demands of not just COVID, but potential other pandemic threats, this is the website I would go to, right? And these e-tools will walk you through step by step by step what's required, where it comes from as a law, give you sample policies, help you understand frequently asked questions documents, and then you can also engage with OSHA on any questions that you have. And a lot of people are not familiar that OSHA has two different sides of the house. They have the regulatory enforcement division, and then they have their consulting arm. And the consulting arm I use quite frequently. And these are folks that are previous OSHA inspectors that no longer do enforcement, but they actually consult with businesses to help them make sure that they're maintaining the standards of care and also meeting the letter of the law. And so this is a great resource that a lot of people don't realize, and it's completely free of charge, and they can't share any of the information with the regulatory side. So if you've got an issue that you call them up about, they're there to help you do that. And that way you can sort of have some of the basic protection systems in place up front. My absolute favorite resource, though, is the Asper Tracy Guide, which is the infectious disease playbook, right? This is one that is extremely helpful. I carry this thing with me everywhere that I go. I have it in a binder, and it really helps us guide, hey, what do I do about this pathogen or this potential route of transmission or this potential source? Do I need to do any prophylaxis? Where are the best resources on CDC's website, for example? And so this is something that every faculty member should have. It should really serve as the basis for your designated infection control officer training and really be sort of the guidebook to do that. It is a fantastic resource. I can't say enough nice things about it. This combined with sort of the access you have with CDC and OSHA will really give you every tool and resource that you need to be successful, whether you're teaching students for the first time as new potential providers or working with EMS providers that are already currently practicing. It is an excellent resource. We also need to think about specific high-risk procedures. And I picked this one out on purpose, as you can probably all imagine, which is aerosol generating procedures, right? And so there's an example list there, not all inclusive. But what I want to call out specifically is if we have an AGP, right? Let's say that we have a patient that is wheezing and we need to give them a bronchodilator. So, they need some albuterol as an example. There's a lot of places that were very afraid to do that because they thought, well, I don't want to produce aerosols in a confined environment like an ambulance, so I'm just not going to do it. We're just going to wait till they get to the ER and they have a negative pressure room. And in reality, that is not what we should be doing, right? We never want to withhold the standard of care. And so getting our providers of the future, especially on board with this and thinking about what is really right for the patient and what's the true risk, right? Because we've not seen, except one study that I'm aware of, a documented transmission with a nebulizer of COVID to a healthcare provider, right? And in that one case, the healthcare providers were not wearing the appropriate PPE. And so we want to think about how can we minimize the impacts, right? Running our exhaust systems, running our air conditioning systems. If we can, do the nebulizer treatment on scene before we transport and have the doors open. You can even have the patient, go ahead and start that nebulizer and you stand behind them or off to the side, right? There's also ways to install HEPA filtration systems in some EMS units also. If you're teaching students how to do this in a non-clinical environment like a lab, then we could look at things like portable HEPA filtration units to teach them sort of, hey, we can get these things out. The good news is that there's lots of new products that have come out to address COVID risk. One of the ones for ventilator circuits as well as nebulizer circuits is it's got a filtering technology. So on the other end, as that air comes out at the backside, depending upon what type of, if you're using a T-piece or whatever, then you can actually put a filter on the other side. So the exhalation is going to be completely blocked with an antiviral filter, which is going to be helpful because that way you can prevent anything from going into the air that's going to be problematic for us. And then from a basic microorganism standpoint, this happens to be measles, right? But the student needs to recognize not necessarily what's under the microscope, but what's really in front of their face. So is this somebody who's got a rash? Do they have fever? They've been outside the country. They say that they have a high risk exposure. Do they have sort of a symptomology set that meets Ebola or COVID or whatever it may be, right? And as soon as we know what that potential organism or fear is, then we need to take appropriate actions to, intervene, whether that's masking the patient, masking us, ensuring we've got, the exhaust fan running as an example. Wearing eye protection is another huge one that I see a lot of gaps in because people just don't think about it. And so this is always going to be a potential problem for us. And as I mentioned earlier before, and I'll say again, if you have a patient with a rash or fever, then we need to make sure that there's a mask, right? That's a red flag for potential airborne transmission, especially for things like measles and some of the other pathogens. And it's always just a good practice. If I've got rash and unexplained fever, to just go ahead and mask the patient and mask us as an airborne precaution. And again, they can deal with this when you get to the emergency department, but something that we should teach our students, especially when we're doing full head to toe assessments, we start to see these weird rashes. A lot of times people don't think about that, because they sort of zero on this must be a dermatologic issue or something like that. In reality, it's actually an infectious disease issue. We've also seen changes in how we're teaching certain things, like our emergency cardiovascular care guidelines. There was sort of this whole premise earlier in the pandemic about let's just not resuscitate these people in some jurisdictions. And of course, that caused a lot of issue, rightfully so, because we can absolutely safely resuscitate these patients, but we need to do it in ways that is going to minimize the potential impact to the healthcare team, especially when we're going to have large amounts of people that will come into the area because we simply need the bodies, right? When we're doing CPR and other things. Intubation is another one that comes where people were selling these thousands of dollars in intubation boxes that you put over the patient's head. In reality, that's really not necessary. There's no evidence that shows that that is going to reduce risk. That's a very expensive thing. It's not going to fit in an ambulance. And so we want to make sure we intubate as quickly as possible in patients that need it and sort of get on the road and get moving so that we can stay safe. And I wanted to finish our time together sharing with you a couple of my favorite tools and resources that I hope will be helpful for your classroom, but also if you're doing any type of continuing education related to COVID or other infection control topics. Some of these are related directly to COVID. A few of them honestly could be really used across any curriculum conversation that you're having related to infection control. The first one is one that really speaks to first responders and the vaccines. The overall rate of acceptance for these COVID vaccines and first responders is still pretty low. We continue to see a lot of room for improvement here. And there's just a lot of generalized vaccine hesitancy. Should I get the vaccine? Should I not? I can't afford time away from work if I get sick. I'm worried about how quickly they were developed. There's a whole host of different issues that are associated with that. The second one is what we call Project First Line. And this is a new initiative that was formed through the CDC, and it will be launching in the next few months in all 50 states and US territories, right? So if you're looking to get involved, you can contact your local health department at the state level, and they can certainly get you engaged. It's a great free training curriculum that's available. And it's all about getting infection control content to frontline providers. So it's really designed to get, again, frontline providers sort of enrichment activities with hand hygiene, use of PPE, what to look for, how to disinfect surfaces, all those types of things. And it's super, super elementary. So it's not designed to be for advanced enrichment or anything like that. It's really designed to give, especially students, get their feet wet with these concepts that will keep them safe. So here's the episodes that are currently available. Most of the video training is anywhere from 3 to 5 minutes. It's very super simple. The link is included there at the bottom. And Nate has also published that in the chat box for you as well. They will continue to add to this. I think just in the last month, they've added about 10 new episodes. And you'll notice that a lot of them are geared initially towards COVID-19 for good reason, but they will continue to transition to other things. And so these are the remaining episodes that are available. Things like, what is a respirator? How do we wear an N95? How do you test the fit of that? All of this basic information. And these are things that as you go through your curriculum, you can easily add these, right? These are just a few minutes each. You can make it part of the students' learning activities, and certainly will make them more marketable as they graduate and go into the profession, and certainly be a lot safer as they're working with patients out there with potential risk. And another one that I really enjoy is from SAMHSA, that is a just-in-time delivery sort of training for EMTs to help them be able to give the vaccines. What we're finding is that there are states and localities that have vaccine, but they don't have enough trained people to give it. And so as part of that federal order that came out last year, EMS providers are able to participate in this. And many states already allowed this as part of their state scope of practice during a declared public health emergency. We're even seeing disciplines like pharmacy technicians, which historically have never given vaccines, are now being trained just in time. So there's a video here to train on the IM injection technique to make sure that they're aware for looking for signs of life-threatening reactions, as well as a training manual. And so this again will help get them ready to make sure that they have those additional skill sets necessary in order to be successful out there within the marketplace. It also makes them more marketable when they get into practice because they have additional skill sets that maybe the student next to them did not. So I did want to include a couple training opportunities that are available. The first line video is there. I've included the EMS COVID resources, the just-in-time delivery. There's also the first responder guidance, which is current as of today. There's been no changes to that. And then the Train Network has got about 7 or 8 free courses that are designed specifically for COVID. And then there's also some that are designed for more general infection control content that you're welcome to use. So as we think about where do we need to go moving forward, hopefully this 2-part series has been helpful in thinking about, hey, let's address the core practices of infection prevention and control and incorporate those CDC tools into my day-to-day practice, as well as my sort of educational methodology. We can also use those just-in-time delivery systems to say, hey, we're going to have an opportunity for you next week. Yes, you're a student, but we're going to give you real-time clinical experience at a mass vaccination site. So we're going to spend the next few hours going through what that needs to look like and how you can safely deliver that. We can also take the core practices from CDC to make those into competencies, right? To say, hey, you need to be able to demonstrate to me that you can recognize infectious illnesses, that you can recognize the route of transmission, you can take the appropriate steps with isolation and correct use of PPE. Those types of things, all the way down through hand hygiene, putting on your PPE, removing it correctly, reporting things to your supervisor, and doing things like surface disinfection and protecting yourself during high-risk procedures like intubation or a nebulizer treatment. Part of this is going to be to making sure that students are properly fit tested, right? And this is a big one. I don't know about right now currently, but I know in the last few months, it's been almost impossible to even get fit testing supplies because they were just such high demand. And so that may be something that you have to work with your local, hospitals or other resources that might have those available. You can also do a simulation activity, like I mentioned earlier with the squirt bottle, to say, let's look at the route of transmission, get you dressed up in the appropriate personal protective equipment, and then actually see how you react. right? To make sure that you're appropriately doing that. And a lot of this can be brought to light visually through the use of things like Glow Germ, as we talked about before. You can also sort of think about the cognitive aspects by creating a germ jeopardy game, right? And all of this is designed to keep the students safe, keep the faculty members safe, keep the patients safe, and keep our practicing EMS colleagues safe as well. So if you do have any specific questions, I would invite you to email those if you have any questions after the fact. And Nate, I'll turn it back over to you, see what questions we might have had that come in through the chat box in the Q&A.
Thank you, sir. I really appreciate you sharing with us today. So you touched on the vaccine, and we have recently seen the Johnson & Johnson vaccine be approved for distribution. And one of our questions is pertaining directly to that. Could you speak a little bit more on the vaccines and which one might be more effective versus the other kinds? And also maybe a little bit on vaccine hesitancy as well.
Sure. So the newest vaccine that received the emergency use authorization this past weekend was the Johnson & Johnson, which is a viral vector vaccine. So it's not an mRNA vaccine. One of the big advantages of mRNA technology is it allows rapid advancement and production. So it's very easy to reproduce related to that. But if you look at sort of the overall outcome of the vaccines, right? What was the original intent of them? It was twofold. One was to keep you from dying, and the other was to keep you out of a hospital. All three vaccines do that extremely effectively. Even after one dose of the Pfizer and the Moderna, even though they're 2-dose series, after one dose, your chance of dying or being hospitalized is reduced greatly. So that's sort of piece number one. Piece number two, which is where people get confused, is sort of the overall efficacy. So if you look at the Johnson & Johnson, I believe it's about 66% compared to 94% for the Pfizer and Moderna. And that's what people have honed in on, right? And so, yes, it may be less effective at sort of reducing the risk of you developing infection, but as far as keeping you out of the hospital and keeping you alive, it's going to do a great job. And so any of the vaccines that were available, I would strongly recommend getting, whether it's for a student or a faculty member. And we'll see the same thing come out with the AstraZeneca vaccine once it's finally gone through the FDA process as well. But I would be very confident recommending all three. The advantage of the J&J one, of course, is that it's one shot. So you don't have to have people come back. So from a logistics standpoint, it's a lot easier. You can also take it in a wide variety of different places because it only requires refrigeration versus a freezer storage. And I think the second question, Nate, was about vaccine hesitancy. Is that correct?
Yes, sir.
Yep. So, I mean, in a nutshell, vaccine hesitancy is the fear that the vaccine will do something negative. So, is this going to make me sick? Am I going to get the virus? So we've seen this for years with the flu shot as an example, where people say, I'm not getting the flu shot because I don't want to get the flu. Well, there's no live virus in the COVID vaccines for the mRNA. There is a live virus in the Johnson & Johnson vaccine, but it is not the COVID virus, right? And so a lot of people hear that and they get very confused. That vaccine uses an adenovirus as essentially a vehicle. So think about it like you're putting your friends in your car and you're going to drive down the highway. The car itself is the adenovirus, and inside of the car are all of the elements to give you immunity to COVID. But none of those elements, none of those friends inside is related to COVID, right? So it's not going to be able to actually give you a COVID infection, and the adenovirus that's used is not able to actually cause you infection as well. It's a non-pathogenic strain.
Wonderful. And so once a student is vaccinated and they come back to the classroom, if they're exposed to a COVID positive patient or anyone, would they still need to be quarantined, or are there different protocols?
So if you were to ask me that question 3 weeks ago, I would have to say yes. But the new guidance from CDC as of a week and a half ago is that if you have someone who has an exposure to COVID, they have been vaccinated and they've completed their series, whether that's 2 shots or 1 shot, and it's within 90 days that they've been vaccinated, then they do not have to quarantine, right? So if it's within 90 days, they've been vaccinated and completed the series and they're asymptomatic, they do not have to quarantine. And that is a new thing. And the reason being is that there is absolute known effectiveness of the vaccine up to 90 days with any of the vaccines that are out there. They much likely last a lot longer than that, but there's no reason to quarantine those folks. The same would be true if you have somebody, for example, who developed COVID infection and recovered. We talk about sort of the theory of when should they get the vaccine and should they even get the vaccine because they already had COVID. And we use the same recommendation. 90 days after recovery of infection is really the ideal time frame by which you should get the actual vaccination, because the rate of reinfection is very low during that time frame.
Awesome. And do you think we should teach EMTs how to give vaccines as part of the current programs to help with mass vaccination?
100%. I mean, again, it's all about marketability and scalability. So if you've got students that are able to go out and help, well, let's absolutely use them. It is a great experience for them, and it's also great for the community. It's a great way to get the program and the reputation of the professionals that you're building out there, and it helps us increase the bandwidth because people are tired. As a matter of fact, when I got my second COVID vaccine, it was given by a paramedic student, and I thought she did a stellar job. And she was standing there with a faculty member that I knew, and it was just like they were so excited to have that opportunity to do that for the community and also get that experience. Because think about it, where else are you going to get hundreds or potentially thousands of replications of proper vaccination technique given an IM shot? We don't give a ton of IM and medications in EMS like people might think, and so it's a great opportunity for learning as well.
Awesome. And I think that dovetails into a great question that we can go ahead and wrap up on. But what do you think we can do to prepare our students for the true frontline impacts of a pandemic prior to having them experience them firsthand?
That's a tough one. We've seen sort of the clinical endpoints of what we've experienced, but I don't think we've seen the PTSD impacts of what our providers, especially those on the street, are experiencing. So I think part of this is to really think about ways to get students based in simulation activities so that they can sort of understand what it's like to wear PPE for a 12-hour shift. Even if that's having them sit in class in full PPE, so that they can sort of feel what that feels like in the hot of a summer, which is, of course, the worst time for us to have all this going on. That's one strategy. The other is to give them sort of exposure to that in the clinical setting under controlled conditions. I know, for example, at a service that I work at, they don't allow students to ride in the back on a COVID patient, which, I can understand that from a risk standpoint, but it's also a missed learning opportunity, right? If I can help that person be safe and I'm confident in their abilities, then let's give them that exposure so that they can understand what that really feels like, to really not be able to communicate effectively with your patients because you have on a mask, to not be able to report to the hospital emergency department very easily because they can't understand you through the mask. These are all things that you can only really learn on the job. And so I think the more exposure we can give them, the better, but that can only be done in the safety of having good competencies up front. So they need to have sort of those classroom-based skill sets up front. And then I think we can expose them more and more as time goes on to some of the things that they would experience in the back of a truck.